name is Dr. Matthew Meehan. I'm a neurosurgeon specializing, among other things, in surgery for epilepsy. And part of the reason I got involved in this field, and a little bit of what I hope to share with you tonight, is it's really exciting to take care of patients with epilepsy today, because so much of what we can offer is changing. And what I hope to share with you tonight is a little bit about the latest and greatest in terms of therapies that we have out there in the past 10 years or so. I would think of it more as a highlight reel than a comprehensive list, but we're going to cover a lot of ground tonight. So I'll start by just saying that we're going to talk about a variety of technologies and therapies, pharmaceuticals. I do not have any financial stake in anything that we'll discuss tonight. And importantly, we will discuss some therapies that are either investigational or are in existence now, but are considered by the FDA as off-label. So just a caveat. By way of outline, we'll start with the background on epilepsy and then zoom through each of the kind of categories of therapies that you can see here. I'll make a quick plug for a website that I maintain that has pages on epilepsy and then on all of the surgical treatments that you'll hear about that I offer. And we'll send this link out with the rest of the information that we'll be describing here tonight. So just by way of background, epilepsy, as Wendy mentioned before, is of course a very common neurologic disorder. At any given time, something like 1 to 2% of people are affected. And we know that about a third of them, so 30 to 40%, despite all of the therapies that we bring to bear for epilepsy, continue to have seizures. And these uncontrolled seizures can have a variety of effects on their life. And they have been the focus of the advancements that I'll be discussing tonight. We've seen that in the past 3 decades, this data only goes through 2014, but despite a number of advances in drug development, it's still about a third of patients that cannot control their seizures with medications alone. And uncontrolled seizures, I don't have to tell the folks listening tonight, can have a variety of effects, not only on a patient's health, but also their life, their psychosocial health. Problems can be things like difficulty in maintaining a job, changes in quality of life, changes in thinking or memory, what we call cognitive decline. And then, of course, the really catastrophic outcome in epilepsy that we worry about, which is sudden death or SUDEP. And so taking all these into consideration, we have a very strong mandate to take care of patients with refractory epilepsy. And yet, despite that, epilepsy, we know, is really undertreated, both in the United States and then across the world. I'm a surgeon. Of course, I focus on surgery, and so this is some data for surgery, but we think there's probably about 1 million patients in the United States that have drug-resistant seizures. And despite that, despite the fact that most of those patients would be candidates for some kind of surgery, the percentage of patients that get surgery is something like 0.3%. It's despairingly low. And it's through events like this one that we're trying to raise awareness and make patients and their caregivers aware of the options that are available out there for them. And my message, and I'll mention this again, is I think for patients and caregivers today, there's hope. We have new developments in pharmaceuticals, technology, and surgery that are really transforming the way we treat patients with epilepsy. The toolkit, so to speak, that we have to take care of patients has changed dramatically in just the past decade. And pretty much everything I'm going to talk about tonight is a development from the past decade. And my message to patients is that you have options. So try to understand what they are and as best you can, be your own advocate. So we'll start with medications. I want to review some of the most recently approved drugs that we have available in the United States, roughly in chronological order. The first I'll mention is Clobazam, or sometimes known as the trade name Onfi. This is a benzodiazepine medication. So it's similar to other medications that may sound more familiar, things like Valium or diazepam. It acts on a GABA receptor, but it has the advantage that because of the way it interacts with that receptor, it's potentially less sedating than other medications. It was approved in the United States in 2011 as an adjunctive treatment for Lennox-Gastaut syndrome. And it's been approved elsewhere, and it's used in the United States off-label for some of these other indications that I've listed. At the bottom, this is data from the pivotal clinical trial that led to approval of Clobazam. And what you can see is that patients who received low, medium, or high doses of the drug fared much better than those who got a placebo in terms of the number of drop attack seizures that they had during the clinical trial. Another drug, Perampanel or Fycompa, was approved just a bit later. This is a novel mechanism. It antagonizes a receptor called the glutamate receptor, or specifically the AMPA receptor. It was approved in 2012 and currently can be used on label for partial onset seizures and for primary generalized tonic-clonic seizures. And I have a little bit of the data from the clinical trials here at the bottom. This is a trial where patients were given either placebo or 2 different doses of the drug, and you can see the responder rate, so patients that had at least a 50% reduction in their seizures was far better in the drug group. And we saw that these effects persisted over time after the clinical trial was over. Briviact is another medication that is a cousin of one that may sound very familiar, levetiracetam or Keppra. It has a similar mechanism, but the way it works suggests that it may actually be less prone to causing psychiatric side effects than Keppra. There's not been, to my knowledge, head-to-head studies of the effectiveness of this versus Keppra, but data suggests it's at least as effective and again may have fewer cognitive side effects. Cenobamate is a newer drug that was studied as an add-on drug for adults with partial onset or focal seizures, which is what most adults have. And this is data from the clinical trial that led to the approval of that drug, showing that patients who got the drug at different doses versus a placebo fared far better in terms of the median number of seizures that they had. And we can see that with higher doses of the medication that this persists over time. So an exciting new drug. A drug that's not in widespread use, but can be quite useful, or data are suggesting is quite useful for a limited subset of patients with tuberous sclerosis, is something called Everolimus. And this is a medication that was used in tuberous sclerosis to treat tumors that TS patients can sometimes get called SEGAs. And it was observed that as a kind of an added benefit of this drug, that these patients also enjoyed a reduction in their seizures. So that is now being used as well. But perhaps the drug that may apply to the widest group of patients watching tonight are the 2 nasal sprays that have been approved for seizure rescue. So these are not typical medications that you would take on a daily basis, but medications you would use to rescue, so to speak, from an episode of repetitive seizures or status epilepticus. So there are 2 nasal sprays. Both of these are benzodiazepines, so similar to Clobazam that I mentioned earlier, but a little easier to administer than something like Diastat, which of course could be cumbersome in an emergency. So it's indicated for these episodes that occur where seizures occur very frequently, close together. And there's some evidence that it may actually reduce the risk of recurrent seizures after that episode for at least 24 hours. So shifting gears, I'm going to talk a little bit about diet. I think a lot of people tonight are probably familiar with the ketogenic diet, which has been, the main therapy we've thought about in terms of diet for epilepsy. It emphasizes fat over carbohydrates and protein. And it was actually first described for epilepsy in the 1920s, so a long time ago, almost 100 years ago, but kind of fell out of popularity and then had a resurgence in the 1990s when it was featured on a news program relative to a young boy named Charlie, whose father started him on the diet and saw a big improvement in his seizures. And there's now a foundation named after Charlie, and the diet is now in much more widespread use than it had been prior to that publicity. We actually don't understand how this diet reduces seizures. There are a number of mechanisms that scientists have postulated. They may work together to some degree, but the ketogenic diet at some level mimics something like a starvation state in the body. And as a result of that, many patients notice a reduction in their seizures. The reduction can be quite dramatic, and I'll show you a little bit of data relative to that. But I'm sure as some people on this call know, it can be hard to stick to this diet. And in certain patients, it can actually lead to certain health problems. So we have this traditional ketogenic diet that I'll describe now, but I'm also going to describe several variants that have come into popularity in the past few years. So the traditional ketogenic diet, again, emphasizes fat, some protein, but very little carbohydrate. Most of the clinical trial data we have for this are for children. And from one meta-analysis that I think looked at 25 different studies, the statistic that we have is that about 60% of children on this diet see at least a 50% reduction in their seizures at 6 months. So this is the kind of effect that accumulates over time. It does not occur right away when the diet is initiated. And as a result of this data, there was a 2018 consensus recommendation from experts that recommended offering this diet to children who had failed trials of at least 2 medications. But the diet can be restrictive. There's quite a few limitations on what people can eat, and there can be a number of challenges. So things like diarrhea, nausea, reflux, or other GI symptoms. It can actually raise your cholesterol in certain patients and then cause mineral changes in the body that can cause things like kidney stones or a loss of bone mass. And so it's been this restrictiveness and side effects that have led dietitians and scientists to look at alternatives to the traditional diet. One of them is the medium-chain triglycerides diet, or MCT diet. MCTs are a type of fat that is metabolized in the body in such a way that less total fat is needed to generate the same number of ketones in the body. So potentially less restrictive. Sources of MCTs, common food that has a lot is coconut oil, but there are also commercially available additives that can be added to food to supplement MCTs. Depending on how you use the diet, the proportion of calories from these fats, these MCTs, can be varied, and there are typically numbers between 30 and 60%. And there's been at least one randomized controlled trial that found no difference in the effectiveness of this diet in reducing seizures versus a more normal or traditional ketogenic diet. The challenges of this diet are very similar to what you might see for the ketogenic diet, so primarily GI complaints, vomiting, diarrhea, and abdominal pain. Low glycemic index is another diet that's being studied relative to epilepsy. This does not actually require a specific proportion of calories to be from fats. It's a little less restrictive, and it allows certain kind of carbohydrates that are restricted under the ketogenic diet as long as their glycemic indices are less than typically 55. Glycemic index is a measure of how much your blood sugar raises in response to a portion of food. And so certain carbohydrates under this diet are permissible. So things like certain fruits, beans, barley, tortillas. And so in some ways, this is a little bit easier to tolerate for some people. We do have less data for this than other diets, and so it's hard to say if it's as effective as the ketogenic diet, but there are some studies that are ongoing. As with the other diets, the challenges can be changes in your metabolism, and one of them is acidosis that can cause a variety of symptoms, some of which I've listed here. But I think this underscores why it's so important, if you're considering one of these diets, to do it under the discretion and the monitoring of your doctor. And then finally, the modified Atkins diet. The name of this diet is probably very familiar to most folks. It was popularized as a diet for adults to lose weight, but with some modifications, there was a suggestion that in fact it could actually reduce seizures as well. Again, it emphasizes fats over carbohydrates, but there's not as much restriction on proteins in this diet versus the other diets. And again, we're still getting studies of the modified Atkins relative to epilepsy, but it does appear that around 50% or 45% of patients have at least a 50% reduction in seizures at 6 months. So can be fairly effective for the right patient and perhaps much more easily tolerated than the traditional ketogenic diet. So I've listed a few links that are great resources for these different diets. Again, these are not the kinds of things that you would try on your own, but rather under the discretion of a physician. These websites offer things like recipes and guidelines and sometimes support forums to discuss the diets with other people who are trying them. And I've highlighted down at the bottom, there are at least 2 keto clinics in Colorado that I know of, one for adults and one for children. And those are the contact information for the coordinators. So I want to talk a little bit about CBD. I'll make the caveat that I think there's going to be another session, in this series about CBD specifically. So we're only going to talk about it for a few minutes, but this has of course gained a lot of attention and press and popularity recently, especially in a state like Colorado. But CBD stands for cannabidiol. This is one of the chemical components of the marijuana plant. It is not the component that we think causes a high, and the data that we have today do not suggest that this is a chemical that is prone to abuse or has a lot of dependence potential. It's available commercially as a medication called Epidiolex. And some of the side effects I've listed here: sleepiness, GI complaints like diarrhea, fatigue or loss of appetite, and in certain cases, changes in your liver enzymes, which is why this is a prescription drug and should be taken under the monitoring of a physician. I'll go through a little bit of the evidence that we have for CBD. So we actually have 2 excellent randomized controlled trials. The first is called the cannabidiol in Dravet syndrome study. This looked at patients with this particular epilepsy syndrome and randomized them either to receive a placebo or 20 milligrams per kilogram of CBD. And what they found when they looked at convulsive seizures was that after 14 weeks of therapy, patients in the treatment arm of this study had about a 50% reduction in seizures versus only 5% in the placebo, so quite a big difference. Cannabidiol has also been studied for Lennox-Gastaut syndrome. This was a similar kind of trial, so a randomized controlled trial. Patients were given either a placebo or one of 2 doses of CBD. The primary outcome for this trial was the number of drop attacks that patients were having, and they found that the rate of drop attacks was far lower in the CBD groups than in the placebo group. And they also noticed that the total number of seizures for these patients was reduced. And this is just some data from the clinical trial. But those 2 trials led to the FDA approval for CBD for those disorders. But we also have some observational data suggesting that CBD may be effective for other types of seizures as well. So this was the CBD EAP safety and efficacy trial data. A little over 600 patients were given varying doses of CBD up to 50 milligrams per kilogram. This was not a randomized controlled trial, so we have to take the data with a grain of salt. But in the trial, they noticed that the median reduction, so the more or less the average patient saw about a 50% reduction in their seizures at 12 weeks, and that was carried forward to almost 2 years when the study concluded. Again, they included patients with all types of epilepsy, not just the 2 syndromes that I mentioned before, but the dropout rate was significant, about a quarter of patients, and that mostly related to the side effects that I showed on the first slide. Here's just a bit of data from that study. So to summarize, we have actually quite good quality evidence and FDA approval for using CBD in Dravet syndrome and in Lennox-Gastaut. And there are several studies that are ongoing relative to CBD for other epilepsy syndromes, and at least one for TS. CBD is prescribable and available in the United States as an oral solution called Epidiolex. But there can be side effects that mean that this is not the right drug for every patient. And it's important to talk with your doctor about whether this is a good option for you. A few words on devices. So this is just a small sliver of what's out there, but I wanted to highlight a few categories of tools that we have available these days. The first is sleep activity monitors. So these are devices that can be placed in the bedroom and watch a patient while they're sleeping to understand if they're making movements or sounds that are suggestive of a seizure during sleep and could potentially be a source of danger for that patient. And there are algorithms that help identify signs of seizures to alert family members, much like a baby monitor. There are also wearable detection tools. So for example, software that can be added to a device like an Apple Watch that again uses an accelerometer and changes in heart rate to try to understand when a seizure is happening and then alert a caregiver or an emergency service. And then there are also proprietary devices like you see pictured in the bottom right that can achieve the same thing independently in a non-commercially, non-over-the-counter device. There are anti-suffocation pillows. I'm not aware of the data specifically for this, but the idea makes sense, which is that one of the reasons we think people are at risk of SUDEP is perhaps if they land face down during a seizure that happens at night. So this is a pillow that actually is porous enough that if you were to land face down on it and not realize what was happening, you would not suffocate. You could theoretically breathe through the holes in this pillow, and it would not be a danger to you to be face down. This is a cool device that I saw and is manufactured by a team in Sweden, but is being studied, or analogs of this are being studied for epilepsy. So this is a bicycle crash helmet, but it has an accelerometer in it that detects when you're falling, and as a result can inflate to try to protect your head from hitting it on anything hard. The benefit for cyclists is obvious, but it could also be quite helpful for patients with drop attacks, for example. And I think there's at least one clinical trial that's looking at this kind of technology. And then not quite a device, but I didn't have another category to place this in. Seizure dogs. So, we have medical dogs that can help patients with a variety of conditions, seizures and epilepsy among them. These are wonderful animals, can be exquisitely trained to do all sorts of tasks to help their owner. Even I saw some dogs can make an emergency phone call by pressing a button on a phone to alert a family member or 911. They can retrieve medications, all sorts of things. These are usually Labrador retrievers, and there's extensive training that is required for these animals before they can be adopted. And as a result, they can be quite costly. But for epilepsy patients, there are frequently sources to help defray some of the costs or assist with some of the cost, and so they're not so prohibitive. I've listed a few organizations that provide these dogs, and again, it can be a great asset for the right kind of patient with epilepsy. So we'll turn lastly to a subject that's near and dear to my heart, and I want to make sure that we have time for questions at the end. So this is not going to be a comprehensive listing of everything that's out there. I just want to highlight some of the things that are new and we have to offer for patients in 2020 that we didn't have even 5 years ago. By way of background, I think sometimes people can have the misconception that epilepsy surgery is a really dramatic and dangerous thing that is only to be undertaken as a last resort. And that's really not the case. So epilepsy surgery, I would say, is for anybody who has seizures that are frequent and or disabling, disruptive to their life, that have not been controlled after 2 or 3 medicines. And there are a variety of seizures that we have, variety of surgeries that we have that are far less invasive than what we've had historically. So some benefits of surgery, in certain cases, certainly surgery can be curative, can make a patient seizure-free. Sometimes it's not, and even when it's not, it's important to understand that all of the surgeries I'm going to describe have good data that suggest patients enjoy a better quality of life. Technology that we have for surgery is improving rapidly. I'm sure the tools that we have 5 years from now will be different from what we have today, but the tools that we have today look far, far different than what we had even 5 or 10 years ago. And again, my message is that patients have options. And so it's important to understand what they might be by meeting doctors like myself or your neurologist and customizing these therapies to you and your family's needs. One of the first important steps we have in surgery for epilepsy is just trying to understand where seizures start in the brain. Most seizures in adults, at least, are what we call focal or partial onset seizures, meaning they start in one part of the brain and then spread. They can culminate or end in a generalized tonic-clonic seizure, but often these seizures start in a single place. And a seizure I compare to something like a wildfire. As a firefighter, if I want to stop the next fire, my goal is to try to understand where it's likely to start so that I can treat that area of the brain. We have a variety of tools for localizing seizures, things like PET scans and MRIs and EEG, of course. But one of the limitations of a scalp EEG, where we put the electrodes on the skin, is that sometimes the source of the seizures is very far from the skin. It's very far from where the detectors are. And so it can be quite confusing where the seizures are actually starting. So to address that possibility, we have a new technique. It's actually not quite new, but it's only been introduced to the United States really in the last 10 years or so, called Stereotactic EEG, or SEEG. This is a technique where we insert tiny electrodes about 1 millimeter thick into the brain to try to understand where seizures are starting with millimeter precision. This is how SEEG started back in France in the 1960s, and I've always liked this picture because the patient is smoking a cigarette in the hospital, and it's a very French thing to do. But SEEG looks very different today. We now use a 3D planning software to map out where these electrodes are going to go. I use a surgical robot that you can see pictured here in the center of the screen to help aim the electrodes. And we can introduce them to the brain really with just kind of tiny 2 millimeter incisions. This is not the kind of thing where we have to do a big craniotomy, which is what we had to do traditionally to monitor the brain with electrodes. And as a result, this procedure is much easier for patients to go through, much less morbidity, and a much easier hospital stay. Now, what do we do when we find out where seizures are coming from? One of the surgical options that we have that is relatively new is something called laser interstitial thermal therapy, or LITT. This is a minimally invasive technique in which we make a tiny incision in the skin and then insert a thin laser fiber into the brain with the goal of burning or damaging some of the tissue that's causing seizures. This is an excellent complement to the procedure I just mentioned, SEEG. And importantly for patients, it does not require a big incision, a craniotomy, and most patients after this procedure can actually go home the following day. We have one of these lasers at Swedish Medical Center. I've done a number of cases before coming to Colorado, and I'm excited because we have our first case here in Colorado coming up soon. This is what the device looks like. It's a very thin fiber, and this is the part that goes into the brain. And then a bolt that anchors it in the skull and helps aim where it's going. And once this fiber is in the brain, and you can see it here, we use an MRI scanner to monitor the temperature response of the tissue as we use the laser. So we can understand when we've burned the tissue permanently. And as you can see, this has emerged as a nice alternative to a temporal lobectomy. So here's a patient whose seizures are coming from the hippocampus, which is this structure here. Instead of doing a temporal lobectomy where we have to come in from the side of the head and take out this big chunk of the temporal lobe, we can instead have kind of a very pinpoint focus on the area that's responsible for the seizures. And this is an illustration of how we do it when we're trying to ablate the hippocampus. Shifting gears, so what do we do when seizures are generalized seizures, primary generalized seizures, or when the source of the seizures is a part of the brain that we cannot remove, or perhaps it's more than one spot in the brain? We have 3 different forms of neuromodulation, which is just a term that means applying electricity to part of the nervous system. I'll start with the one that's been around the longest, and that's called vagus nerve stimulation, or VNS for short. The device is getting remarkably smaller. This is a picture I took the other day. You can see the battery is not much bigger than a quarter, but this connects to a little wire that goes into the neck and is connected to the vagus nerve. And this device delivers 3 kinds of therapy. It delivers electrical pulses to the vagus nerve on a schedule, so every 4 or 5 or 6 minutes. It also has a heart rate detection feature. And as we talked about before with the wearable devices, many patients have unusual heart rate patterns at the start of a seizure. So a VNS can actually detect those and deliver extra therapy in response when it thinks a seizure is happening. And finally, VNS has a magnet mode. So it's something like a wristwatch, a magnet that you can wear on your wrist. And when a patient feels that a seizure is coming, perhaps there's an aura, he or she can swipe it over the device to activate the therapy. Or a caregiver can activate the therapy. And we have data from each of these individual therapy modes that show that they add independently to seizure control in these patients. Over time, VNS and the other forms of neuromodulation that I'll describe here in a moment all improve. So the longer you had one of these devices, the better your seizure control. The second form of neuromodulation I want to talk about was approved in 2013, and that's a device called RNS, responsive neurostimulation, or sometimes it's known by its trade name NeuroPace. This is a device that consists of two parts. There's a microprocessor that's embedded in the skull, and then there are up to 2 wires that go into the brain itself. And these wires function like very high resolution EEG, and they're monitoring constantly for any activity, electrical activity in the brain that's suggestive of a seizure. And whenever something that is suspicious is detected, the device delivers an electrical impulse to the brain to try to interrupt the seizure. This is kind of an illustration of that general concept. The electrical stimulation, the pulses cannot be felt by the patient, but they can be quite effective at reducing seizures. So this is data from the pivotal trial that led to the approval of RNS. And what you can see is after a patient has had this for several years, the median reduction in seizures, so basically what the average patient sees, is something like a 70% reduction in seizures. So that can be quite dramatic for certain patients. Another benefit of this device is that unlike some of the destructive therapies that we have that take out or damage brain tissue, this electrical stimulation actually seems to improve certain cognitive functions. So things like thinking and naming and memory. Patients actually get better rather than worse. And strangely, this is independent of how much we reduce their seizures. So the stimulation is helping the brain in ways that maybe we don't even recognize right now, but it works to the benefit of patients. Finally, the third form of neuromodulation, the newest one that we have for epilepsy, is something called deep brain stimulation, or DBS. We've actually been using this for a long time. I use it very commonly for other neurologic disorders like Parkinson's disease or tremor. But we discovered that you could stimulate a different part of the brain called the thalamus, and actually achieve seizure reductions in patients with epilepsy. So it's as effective, just like VNS, for seizures, no matter where they're starting in the brain. And we don't have to know where they're starting in the brain to use this therapy. This is what the device looks like. There's fundamentally 2 parts. There are thin wires that go into the brain, into the thalamus. There's wires that run under the skin. Actually, they run behind the ear, under the skin, down to a little pulse generator that sits beneath the collarbone in the same location that a VNS pulse generator would sit. And indeed, we have data suggesting this is very similarly effective to NeuroPace, or RNS. So just as with the other forms of neuromodulation I mentioned, the longer you have this device, the more effective it tends to be. And at 6 or 7 or 5 years, we're looking at about a 70 to 75% reduction in seizures in the median or average patient. So again, quite effective. That's kind of it for surgery, at least